I'm going to take you through, initially, just a quick revision on how we measure health inequalities in Scotland. I know there's a lot of people who are fairly new to this today, and then I'll spend most of the time talking through what we already know about what works to reduce health inequalities, and importantly, what doesn't work. In case anybody needs reminded, health inequalities matters. Martin Luther King said that of all inequalities, injustice in health is the most shocking and inhumane, and who can disagree with that? Obviously, the loss of life in Glasgow and across Scotland due to health inequalities is massive, and it's preventable, and so therefore it demands our attention. Fortunately, in Scotland, we have an excellent annual report produced by the Scottish Government, which monitors our health inequality trends, and we monitor a whole variety of outcomes, from premature mortality, mental well-being, first heart attacks, heart disease mortality amongst adults, cancer incidence, alcohol first admissions, alcohol deaths, mortality among young adults, low birth weight, and healthy birth weight as well. So we monitor all of these outcomes in Scotland every year, and so we've got a really good picture, a very rounded picture of what's happening with our health inequalities. I'm going to pick just one of these trends to illustrate some of the measures we use to say whether health inequalities are getting worse or better. Oh, I'm sorry, self-assessed health as well, and limiting long-term conditions. I had originally said that all of these would come up at once, but I failed in my PowerPoint skills today. Okay, so I'm going to pick one of them, which is mortality rate for those aged under 75 years. It's a really good measure of health, because we know that in the best countries across the world, the life expectancy is well above 75 years, and so this is very attainable. So it's good news on average. So from 1997 to 2015, you can see that mortality rates have gone down for this group over time, pretty steadily until the last year of data there in 2015. So that's good news. But that, of course, masks the inequalities across Scotland. So if we take the most affluent group, that's that blue line there, you can see that the most affluent group enjoy a mortality rate that's roughly half the average. Okay, so that's the most affluent tenth of the population, has a markedly different mortality rate than the average for the whole of Scotland. And what I'm going to do is just add in each tenth of the population now, and you can see each tenth of the population has a slightly higher mortality rate until you get to the most deprived groups there, and look how much higher the mortality rate is over time. The mortality rates are coming down in all those groups, by and large. They are quite bumpy because it's smaller sized populations, but the general trend is downwards. But that inequality, the gap or the ratio across those groups is largely maintained. And I want to talk a wee bit just about how we measure that so that you can understand what it says in this annual report on health inequalities. So if we present the data in a slightly different way, this is just taking the 2015 data and ranking from the most deprived to the least deprived on the left. You can see that very stark gradient of higher mortality in the most deprived groups is there. And what we do is we draw a best fit line. So the line, a linear straight line through those points. It doesn't exactly match each of those, so it's a best fit. But that's the kind of gradient across the population. And that's important because it doesn't just look at the worst and best. It takes into account all of the groups across the whole of society. And that's also important because even if you're in the middle, so if you are sort of in the fifth decile, the fifth group in that line, you can see that your mortality rates are higher than the most affluent group. So health inequalities affect everybody in society, not just the people at the extremes. Now, what we do is to measure the absolute gap, what's called the slope index of inequality. We draw a line across from the top and bottom of that red line. So you can see it's not equivalent to the highest mark, it's not equivalent to the lowest mark, it's looking at that best fit line. And then we measure the distance between those two lines, and that's the slope index of inequality. That is the absolute inequalities, the gap across the population after taking into account the slight variation across deciles. So that's quite important, and that's one of the headline measures we use in Scotland. And I just wanted you to understand that. But very few people understand what the absolute inequality is. It's even more tricky to understand the relative inequality, but I'm going to give it a go. So just remember what that red line means. So that's the gap. The relative inequality, the RII, is the ratio, or how many times worse things are, which is approximated by taking that absolute inequality, that red line, and dividing it by the average. So we take an average line across there, we measure how high up that is, we compare the size of those lines, and then we take a ratio of them, okay? And that is the RII, that's 1.33 times. So the red line is 1.33 times greater in size than the black line. That's the RII. So hopefully we all understand those figures now, yes? See lots of nods, sort of. But this is important because in Scotland, that's all the data there, but we summarise it in 2 lines. So we summarise it as the RII and SII, and you can see they're going in different directions. And you'll be thinking, what's going on? Why are they going in different directions? I don't get this. So it's because the average is also coming down over this time period, and so we need to understand that they measure different things. So by and large, absolute inequalities, the SII, is getting better in Scotland, but the relative inequalities, the RII, is getting worse, and that's because the average is improving over time. So what we're dividing the absolute by over time is changing. I hope you're all still with me here. So largely, the absolute inequalities, the SII, has been declining mostly because of the decline in heart disease and alcohol-related mortality over time. But as I said, because the average is also improving, the relative inequalities have gone up. Notice that in 2015 in particular, mortality rates and inequalities in mortality has gone up a wee bit. There's a lot of work going on to look at that. National Records for Scotland just published earlier this week that life expectancy for the first time in many decades has stalled in Scotland, and there's a lot of worry about what the causes of that might be, and we'll be publishing some more detail on that in March. So just to go back to that and trying to understand that a wee bit more, this is so I'm just simplifying this graph into 2 lines, so poor and rich here. This is the current situation. So absolute inequalities are going down, but relative inequalities are going up. The ideal, of course, is that absolute inequalities go down and relative inequalities go down. And to achieve that, what we need is a much faster improvement in the health of the poorest groups compared to the rich. And that will get us a decline in both absolute and relative inequalities. So that's what we're aiming for. And what I'm going to hopefully spend the next few slides talking about is, well, what's causing inequalities in general? What do we know about that? And then, importantly, what do we know works to do about it? So, what causes health inequalities? Well, 4 theories have been proposed. There they are there. So, artifact, selection, behaviours and culture, and structural and political economy. I'll just take you through the evidence for these very quickly. So, the first is artifact. That is basically that it's not real, it's something wrong with the statistics, and this isn't the case. So we're very confident that it's not an artifactual relationship. It's not untrue. It's not based on a problem with our statistics. And that's because no matter what indicator of social status or socioeconomic position you use, you see that same patterning in different places and in different times, and it's very difficult to sustain that this is an artifactual relationship. However, that's not to say we can't measure the lived experience of deprivation better. So one of the big limitations of things like the Scottish Index of Multiple Deprivation is that it's an area-based phenomenon. It doesn't work well in all areas of Scotland, we know that, and it doesn't really capture what it's really like for the people within the most deprived areas. And so we need to get better at measuring that. And so it's not to dismiss artifact entirely, but it certainly doesn't explain away health inequalities. Okay. Second theory is selection theory. I call this the zombie hypothesis because no matter how much evidence accumulates against it, you still see it quoted, particularly in the economics literature. In essence, it's a reverse causation argument, so that poor health causes a social slide rather than vice versa. But it's totally undermined by longitudinal studies where you measure social status when you're healthy and then see who gets healthy and who gets sick. And there's lots and lots of longitudinal studies that now show that selection theory really doesn't explain very much of health inequalities at all. The third theory, behavioural and cultural, well, this is a really important theory, but it's partial. So the advocates of it, in a sort of strong sense, would suggest that the prevalence of behaviours such as smoking, alcohol and diet, cultures or skills such as parenting are the root cause of health inequalities. In softer sort of terms, people would say that this is part of the causal pathway. So what we know is that unhealthy behaviours are more prevalent in the lower socioeconomic groups. However, the same behaviours generate higher mortality amongst the working class. So if you compare smokers who are working class compared to smokers and professionals, it's the smokers in the working class that will get higher lung cancer rates, for example. It ignores why particular social groups adopt unhealthy behaviours, the context. The patterning of health behaviours is explained by socioeconomic circumstances. And really importantly, and this is based on a really big study in France, the Gazelle study, where unhealthy behaviours have equalised across social groups, mortality inequalities have not. So it's not all about health behaviours. Another argument against this has been the root cause, is fundamental causes theory that Bruce Link and Joe Phelan have talked about over the years. And that means that over time, the different causes of death that have become important, the different causal pathways have changed. And if it was simply about behaviours, then as behaviours have changed, you would see those inequalities come and go. So, for example, if you went back to Glasgow in 1850, it would be about access to clean water that would be the important driving factor of health inequalities. It wouldn't be about whether you smoked or not. But then it was about malnutrition. Then, over time, environmental toxins such as asbestos and exposures in the shipyards and things became more important. Smoking then became important after World War II. Alcohol and drugs more recently. And as each of these causes of death have been tackled effectively by public health and policy action, health inequalities have been maintained. So even as we, in the future, manage to tackle alcohol and drugs, other future mechanisms, such as obesity that we talked this morning, will become more important in driving health inequalities. All of that means that tackling socioeconomic inequalities in society is the most important thing in tackling health inequalities. So, what this theory argues is that differences in income, resources and power between groups cause health inequalities. We know that because health inequalities rise and fall with income inequalities, and I'll show you a couple of graphs of that in a second. We know that the health of communities has improved when they've been given more resources by chance, and there's references for that. And we also know that those with the most resources in any society are always the healthiest, regardless of their behaviours. And even when you've got genetic factors, such as with cystic fibrosis, the people that die earlier from cystic fibrosis are still the more deprived groups. So it's the context in which people live that's the most important thing. This isn't unknown in our most deprived communities. So there was a study done by Barry McKenzie and colleagues at Glasgow Uni and the University of the West of Scotland, which asked people in post-industrial towns in Ayrshire what they thought about health inequalities. And some of the quotes that they come up with are really, really staggering. So the first one here, I don't know if I can read it. That's the cause of it, his ill health. Aye, the lack of work. See, if I'd been working, I'd never have had any bother because you were that used to working and it kept you fit. So if you're not working, what are you doing? Your system's shutting down. And that's what's wrong with all these men around here. Their systems are shutting down. So people instinctively link unemployment and deindustrialisation with health outcomes. Another quote. Everybody kind of looked out for one another. If somebody was short of money, like the neighbours next door, there was still a long-running joke, the floating fiver, a £5 note. Because this fiver, you didn't ken who it belonged to. It just went between the two hooses. There was more a kind of sense of community. That's not the same kind of feeling now, shut doors and all that. And of course, that's what we would maybe codify as social capital nowadays. But that existed, and people knew that that's what existed within working class communities in the past and what's been eroded since deindustrialisation came on. One more quote. Brian was only, 2 years unemployed when his wife left him. All those unemployed miners was drink and gamble. Did nae work, nothing else to do in the mornings. Got up, go to the pub, come back home, go to the pub. It ruined my brother's life. His wife left. James's wife left him, and a lot of guys in this area. All their wives. All the women were seeing was drunk man coming in. An awful lot of men just seemed to go off the rails. Again, linking health behaviours and cultures very strongly with what was going on in the jobs market, what was going on with the mines in that area. So this is common knowledge in our communities. This isn't new. This evidence is out there colloquially, but also in the academic literature. And just to show that health inequalities tracks income inequalities, this is a measure of health inequalities across Great Britain. You can see they went down from the 1920s to the 1970s before rising, and there's the trend in income inequalities. We don't have earlier trends, and that's for Great Britain. Very similar thing for the USA. That's from 1960 to 2000. The mortality gap has increased over that time, and there's the income inequality trends. So income inequalities is a big driver of health inequalities in society. So, on the causes of health inequalities, we know structural explanations fit best. Behavioural and cultural theories are relevant, but they're insufficient and they need to be contextualised. Blaming poor people for their behaviour, skills or cultures is really quite damaging and stigmatising. Selection theory doesn't explain much, and therefore health inequalities are largely determined by the political decisions and political priorities we have in any society. But really importantly, as those last trend graphs showed, health inequalities are not inevitable and have been lower in the past and in different places in other populations. So, rather than leaving us in doom and gloom, I wanted to spend the last few slides just talking through what we know works to reduce health inequalities. A lot of this is pulled from a report done by NHS Health Scotland called our Health Inequalities Policy Review, which is available on our website. So, just to start, the least likely actions to reduce health inequalities we know are information-based campaigns, so where we're inviting people to opt in to healthier behaviours, less effective at reducing health inequalities. Written materials, campaigns reliant on people taking the initiative to opt in, and campaigns and messages designed for the whole population. whole school health education approaches, not that effective at reducing health inequalities. And anything, of course, that involves a significant price or other barrier to access. We also know that housing and regeneration programmes that raise costs and cause gentrification are ineffective. However, to balance this up, I've got 2 slides on effective actions, you'll be glad to hear. So, structural changes on the environment, so things like area-wide traffic hamming, separation of pedestrians and vehicles, child-resistant containers to stop poisoning, installation of smoke alarms and wiring them in, installing affordable heating in damp, cold houses. All those structural changes to people's environment, really effective at reducing health inequalities. Legislation and regulation, really effective. So drink driving limits, lower speed limits, seatbelt legislation, really effective. More recently, the ban on smoking in public places. And then obviously minimum unit pricing, again, will be a very effective way at reducing health inequalities. And then vitamin supplementation of foods. Again, it doesn't rely on people opting into things and taking vitamin tablets. It's just part of what people do. It's just part of the diet. Fiscal policies, so making unhealthy products more expensive is effective. And then, of course, income support, so boosting people's income, particularly in the lower income groups, equalising the income distribution across society, really, really important. And more recently, we've got some evidence around welfare rights advice in primary care. It's a really effective way of maximising what people actually get in terms of what they're due in social security. The flip side of putting price barriers in place for unhealthy things is reducing price barriers in healthy things. So free prescriptions, free school meals, free fruit and milk, free access to smoking cessation, free eye tests. All of these things reduce barriers and reduce health inequalities. Improving the accessibility of services. We know that the more barriers you put in place, whether it's the infamous primary care receptionist or the need to phone up 15 times to get an appointment for something, the more barriers we have, the more inequalities will result, because we know that the middle classes can navigate that more easily than everybody else. Prioritising disadvantaged groups, so people who are multiply deprived, rough sleepers, unemployed, homeless, and then obviously offering intensive support for those that have the greatest needs. And then we know starting young is really important as well. If we wait till inequalities are ingrained within people's lives, it's much more difficult to turn that around. So to summarise, health inequalities are largely due to politics and policies. Behaviours are important, but only part of that story. Clearly addressing poverty, inequality and the social determinants of health is essential if we're to reduce health inequalities. And the evidence suggests that the most effective actions in that regard involve legislation, regulation and taxation. Thank you very much.